Okay. Well, good afternoon, everyone, and welcome back if you were with us this morning, and hopefully those of you that were had an enjoyable discussion with our speakers and other attendees over the lunch hour. I know that our table, it was a very interesting discussion. My name is Doreen Markle, and I am serving as the moderator for this afternoon's first session. I am a faculty member in the University of Michigan's Department of Learning Health Sciences, and I direct the Brehm Center here at the University of Michigan, which focuses on using a systems approach to solving diabetes research and prevention issues, as well as now applying some of that thinking towards diabetes learning health system projects at the University of Michigan. This afternoon's session will focus on the very important and often challenging concept of equity. And equity can have very many reasons or meanings. So equity is important in many of the discussions that we have about health policy, and it can mean so many things to many different people. It could be about equity and engagement that we discussed a little bit earlier in our previous session, equity in implementation, equity in participant selection, or equity in access to benefits that and the results that may come from them, and so many more definitions that you may have yourself. In many ways, it's the fulcrum concept of the healthcare system that allows us to think about healthcare in an efficient, effective, and just way. So to discuss the important topic of equity, we have three very amazing speakers that I'm honored to introduce to you this afternoon, and we'll be doing the same process as we did with the earlier sessions. I'll introduce all three of our speakers and also the person who's going to be our commentator and facilitator for the question and answer at the end, and then we'll all gather in the front again. There's been a slight change to the schedule, and if you're thinking that you need to have a bio break after lunch, we're going to actually fit one in after this entire session's over. So please stay for the entire session. We'll have a 10-minute break, and then we will go on to the last session of the day. So it is my honor and privilege to introduce to you our three speakers. Our first speaker is Dr. Patricia Kingori. She is a Wellcome Trust Biomedical Society and Ethics Fellow at the Ethox Center at the University of Oxford. Her disciplinary background is in medical sociology, and her current research interests lie at the intersection of sociology, science, and medicine, and the critical examination of ethics in those areas. Much of her work has taken place in East Africa, but she has recently extended the reach of her focus of her research into Southeast Asia and the West African countries. So welcome to Patricia. Our second speaker this afternoon is going to be Mr. Vince Bonham. He is an associate investigator at the National Human Genome Research Institute, Division of Intramural Research's Social and Behavioral Research Branch. That's quite a mouthful. He leads the Health Disparities Genomics Unit, which conducts research and evaluates approaches to integrating new genomic knowledge in precision medicine into clinical settings without exacerbating inequalities in the healthcare delivery. His research focuses primarily on the social influence of new genomic knowledge, particularly in communities of color. Welcome, Mr. Bonham. Our third speaker is Dr. David Magnus. He is the Thomas A. Raffin Professor of Medicine and Medical Ethics and Professor of Pediatrics and Medicine at Stanford University. There he is also the director of the Stanford Center for Biomedical Ethics and co-chair of the Ethics Committee for Stanford Hospital. He is also the former president of the Association of Bioethics Program Directors and the current editor-in-chief of the American Journal of Bioethics. Welcome. Our fourth colleague is joining us today is Dr. Scott Roberts from our own Department of Health Behavior and Health Education in the University of Michigan School of Public Health, where Scott is an associate professor. He is also the director of the School of Public Health Genetic Certificate Program, and he serves as the co-director of the University of Michigan Dual Degree Program in Public Health and Genetic Counseling. He also leads the School of Public Health's Genomics, Health, and Society program within the Center of Bioethics and Social Sciences in Medicine and Medical School. Dr. Roberts will be joining us for the discussion part of our panel today. So with that, I would like to remind each of the speakers that they'll have 15 minutes, and I'll have my nice little signs to show you when your time is up. And I extend the floor to Dr. Kingori.
Hello, good afternoon. I'm delighted to be here. Thank you very much for extending the invitation to me. I'm hoping I've completely gotten over my jet lag, having traveled here from London. So I wanted also to say thank you very much to the people who came in the morning session. I learnt a lot, and I'm hoping to continue the discussion this afternoon. I've changed the title of my talk slightly. This one hopefully suggests much more of a discussion with the audience and a collective thinking through some of these issues. So today I'm going to be talking about thinking through ideas around race, gender, and socioeconomic status in building systems and structures. Okay, so data is often depicted as being objective and value-free. I don't really need to say that actually, sometimes it's not, but I thought I'd start with that as a starting point. We often think about bias in the way that data is interpreted, but we often don't think enough about how it's constructed and built. And this extends also to the way that systems are constructed and built. So categories and ideas in the design of data can exclude groups, include controversial concepts, as well as shaping outcomes. And that's really what I want to talk a bit about today. Okay, so bear with me here, because I'm going to talk a bit about architecture, but you're going to see how it's really, really relevant, hopefully. So since the 1970s, there's been a growing body of work and literature from the feminist movement, which has constructed a critique around architecture. And I suppose the way of summarizing that critique is that the way that certain infrastructure and public spaces are built, they're built with an imagination of a certain user, a certain person in mind. And that imagination and the ideas around how things are constructed then shape and produce structures which seemingly are inanimate and objective, but shape people's experiences of those things, right? So, for example, feminist critique of architecture has spent a lot of time looking at public toilets and the number of toilets in buildings and where those toilets are. I work at the University of Oxford, which is a place that was built long before they thought about women academics working there. So sometimes you've got to really think about your day when you're working in certain places. Any of you who've been pregnant would also know that if you're heavily pregnant, where you can go, if there are no public toilets there, can really shape your experience of a space, right? So the imagined user is really important in shaping people's relationship to that space. What's also really interesting from the feminist critique of architecture is that once something is built, the individual can't really complain or push back against that system. So if I come here and I'm disabled and I want to get to the podium, there mightn't be anywhere for me to get to that shapes my experience of this space. But more importantly, who exactly do I complain to that can do something about that in that moment? Because the structure is already there. And this is really important to think about some of these critiques when we're thinking about building systems. Also, if we think about ideas of race embedded into everyday structures, I'm not sure how many of you are aware of this sort of some of the thinking that's gone on behind Long Island Bridge, but the architect responsible for building that, Robert Merson, had very strong racial views. They had very strong views about which racial groups should be using Long Island Beach in particular. So he constructed a bridge that was unusually low, which meant that buses couldn't get under it. Only people who owned cars could get under it. And the time when it was constructed, the majority of the people who owned cars were white. It meant that it excluded lots of the black and poor population from getting to Long Island Beach. Now, this is really important, again, thinking about how inanimate objects can actually shape and produce and construct things in a way that makes it a very difficult one to push back against it, because the bridge is there. Well, it's no longer there, but the bridge, once it's there, it's there. But also, if I was thinking about doing some social research on Long Island Beach, say I wanted to just find something out, it really doesn't matter how benevolent my particular views are. The fact that I'm doing my research on Long Island Beach means that the population there has already been constructed in such a way that, in ways that I have no control over. So it's not only that these things exist and they have ideas embedded in them, they go on to produce certain types of social realities that are really important when we're thinking about how things are constructed. So that's one about race. Increasingly, I'm not sure if this is in Ann Arbor, but certainly in the UK and in Europe, we've seen architecture designed with certain populations in mind, and specifically anti-homelessness spaces. I don't know if this is something that exists so much here, but there's a kind of park benches that are no longer, straight across as we would have imagined them, so that anybody can sit on them, but individual park benches where you can't, if you're homeless and want to sleep there for the night, you can't sleep there. Again, these sorts of spikes. So the idea is that the infrastructure is designed to exclude certain types of people. And some of the critique of this has been it doesn't only exclude who you want it to exclude, it can often exclude other types of people too. So imagine that you've been told by your doctor that you need to do more exercise and you need to go to your local park, but you're actually very obese. How exactly are you expected to take a seat in this bench? It excludes other type of people. It extends beyond sometimes the group that it's supposed to exclude. So that actually, when we're thinking about how things are constructed, it's really important sometimes to think about what are the values and who is the imagined person that thing is designed for. So I'm going to talk a little bit about City of Quartz. I don't know how many of you have read this book or aware of it, but it's Mike Davis's kind of seminal work in 1990, where he actually spent a lot of time looking at the way that the Los Angeles was designed, and he presented this idea that actually Los Angeles is predominantly designed by powerful people interested in security, in making it safe. This idea about the construction of the public space as a fortress, where security became this unquestioning good. Who doesn't want to be secure? Who doesn't want to be safe, right? Turns out that some people are far more interested in that than others, and the people with the money construct a city in such a way to make sure that they're more safe than others. So he goes on to argue that if you look at the affluent areas which are fortified, what they do is residential areas with enough clout are able to privatize local public space, partitioning themselves from the rest of the metropolis, even imposing a variant of neighborhood passport control to outsiders. So he looks specifically at the privatization of public spaces, of public parks. So no public toilets, for example, public parks which are closed after certain times, public parks where you have to show ID to be able to get in. And he argues that this has shaped the well-being of the poor and access to affordable forms of exercise as well. So what happens is that you see that a huge variation in the health and well-being of the residents of Los Angeles depending on how much access they have to public space and how much access they have to the ability to exercise. And so this is a really interesting and important point. So if we look at some of the lessons from architecture, we see that implicit in the design and construction of structures and systems are ideas about what constitutes benefit and for whom, how will they be used, and by whom. We also see that these ideas not only reproduce these other implicit ideas, but can consciously construct and exclude certain users. Most importantly, once these things are constructed, these structures take on the appearance of being value-free and objective, right? Yet clearly they're directed by ethical and political interests. Right, so let's have a look at learning health systems. The promise of these are that they're to improve understanding of health inequalities, produce more targeted population-specific responses, reduce costs, for example, improve interventions. They're supposed to be more ethical use of existing resources. They're supposed to benefit more people, produce more objective, value-free data, where error is removed because it's produced on aggregate. Often these learning health systems as big data favor more consequentialist ethical position, i.e. they're more focused on what will come from having integrated systems, what are the benefit derived at population level. and what kind of future has been imagined. So here's some examples of systems that have tried to, of outputs that's tried to integrate different types of data, right? So if you look at this lovely graph here, this has been produced by pooling together lots and lots of different types of data to look at cases of diabetes in North Carolina. And what we see is data constructed at different levels. On the first level, you've got electronic health records, so I think that's the blue level. The second level, you've got single-parent households. And the third level is property values, right? And from that, they're able to give a lovely diagram which shows you that in the red spikes where cases of diabetes are likely to be higher. Now, if we take this as a kind of objective, value-free piece of information, what we're seeing here actually are all sorts of assumptions that are hidden by what's not included. So we had a conversation this morning about the, fast food and organizations. This graph, for example, doesn't include how many fast food places exist in this area. It doesn't include, for example, where the public spaces and government initiatives to make public space available to poor people. So in so doing, it shapes what would look like a solution in relation to this. The solution in relation to this information would be very individualized. What we do is we look at where those cases of diabetes are, we focus on those individuals, and we get them to try and change behavior, rather than thinking about actually what are the social determinants and how is this shaped? What is the information that's excluded from this type of graph? I'm not sure how many of you are familiar with this 8 Americas concept. This again is pulling information from lots and lots and lots of different sources, and has constructed this idea about 8 different types of Americas, which is really important in terms of shaping public health policy. What's interesting about this is that since the 1970s, sociologists in particular have been really anti-including racial categories into analysis, saying that they're essentially pointless, and they're proxy for all sorts of things that really aren't important. What's been the concern has been this creeping back in of racial categories and data that's pooling together all different ideas of racial categories, where some of the concepts and reasons for having these racial categories mightn't be known. So there's, for example, there is no way of understanding or getting access to the metadata that informed all of these different categories. And were they all collected using the same idea of race? Were they all collected using the same idea of justice or ethics? We don't know. The point is they're all here together now, and we've got to try and use this data and make some sense of it. And that's one of the criticisms, is actually all this data has been collected with often very different ideologies, and we don't know once it's been formed in this way. We haven't got access to some of the hidden concepts. Again, so this is in more detail, but I'm going to move ahead. So some of the concerns generated by these learning health systems is often that there's a causation and correlation problem. And we can see that in the diabetes study, where just because diabetes is correlated with specific individuals doesn't mean that there isn't social cause as well. That sometimes these kind of big databases privilege certain types of data, specifically quantitative data, and specific types of approaches over other types of approaches, often presents as value-free and objective definitions of highly problematic characters that are still subject to debate. Privileges in an approach at population level gains, which can medicalize rather than thinking through some of the duties and obligations to individuals. So in summary, just to keep the time, some of the critiques of architecture is relevant to the construction of learning health systems in the field of health. Ideas embedded in the development of categories, variables used to demonstrate relationships between one thing and another are really important, as well as the actual sources of the data. Systems and structures have politics, ethics, and an imagination of their users with positive and negative effects, and I think we need to really take that very seriously. And it's really important to think about how do you include ideas and the needs of women in particular racial groups and those with disabilities and certain economic status, and how do you take that all seriously? Some of this really appeals to thinking transparent. How do we get access to transparent data where we know why that data was collected and whether it actually works with what you're trying to produce or against it? Thank you.
So good afternoon, everyone. It is a real pleasure to be back in Michigan, which is my home, and I feel a very close connection to both University of Michigan because a lot of my money went here because my son graduated from University of Michigan, but also I have so many colleagues and collaborators in the room, and so I'm so pleased to be back home. So let me start with disclaimers. I have no financial or other conflicts of interest to present today, and the statements that are made are mine and mine own. They're not the National Human Genome Research Institute. They're not the National Institutes of Health. They are not the Department of Health and Human Services. All right, so my talk is about the issues of equity and thinking about learning healthcare systems. And my talk is really focused on learning healthcare systems that are genomically enabled, okay? So my frame in my talk is about genomic-based learning healthcare systems. And there was a National Academy meeting and report that was published in 2015 that I want to just kind of put some attention on as a part of my talk that really talks about the potential of genomics and its integration in learning healthcare systems and how it can be beneficial with regards to improving health. And I would like to talk about that from the perspective of the issues of equity within our country and addressing health disparities. So we have a challenge. And the challenge is this, that the potential of learning healthcare, genomically based learning healthcare systems, benefiting issues of importance with regards to health equity and health disparities in our country will be problematic, in my opinion. And this is a quote from the National Academy report. Groups adversely affected by disparities could be among those that benefit most from a learning healthcare system. I don't necessarily agree with that statement, and I'm going to tell you why. So this is a page 27 of the report. This is the only page in the report. Now, I know there's several individuals in the room who were involved in the development of this report and the workshop, but this is it about the issue of health disparities and genomically enabled learning healthcare systems that's presented in the report. And it gives me some concern from the perspective of thinking about this kind of broader context of thinking about the field of genomics and thinking about equity and how we go about really addressing these issues. So my colleague and I have been thinking about this as I prepared for this talk and been thinking about this in a more broader context of how we think about health and equities in our country and genomics, and thinking about how can you enable a learning healthcare system to enhance health equity. What can we do from the perspective of genomics and the integration of genomics within a learning healthcare system? So starting to think about this from clinical decision supports and the integration of clinical decision support, you know, we need to ask questions. What does the current data suggest? And how can that be used to improve care? So what data do we currently have from the perspective of genomics that's been integrated in the clinical decision support, and how that can be important with regards to improving quality of care within populations? And then outcome evaluation. So actually we have what is in the system currently to ask these questions. Does use of genomic information improve health outcomes? And when and for whom? And I think that is an important question that we need to ask with regards to how genomics is integrated into the electronic healthcare record in thinking about learning healthcare systems. And then how can we take the information as we're learning it and modify it to make sure that there's clinical utility for all? So how does this new information change assumptions? What research is necessary to improve information utility? Because I think that we can move forward to enhance the utility of genomically enabled learning healthcare systems for all populations within our country and across the world. But we need to recognize the challenge and understand what the challenges that we're facing. And this work by Dr. Popejoy and Dr. Malia Fullerton is something, if you have not read it, I would strongly encourage you to read it, that was published recently in Nature. Is taking a look at the genome-wide association studies that have been published. So these are federally supported studies that have been conducted where the data is now in the public domain for researchers to use to help in identifying gene variants around disease. And what has happened since 2009 when an original report was done by Carlos Bustamante and colleagues and Dr. Fullerton's report in 2016. So the change has not been that significant. The change in 2009, 96% of all genome-wide association studies in the public databases were of European ancestral populations, and in 2016, 81% of all the samples were from European populations. That's clearly increasing the diversity, but there are still some very significant challenges for our country related to that. So one of the challenges is that during the past 7 years, the proportion of samples used in the catalog, the GWAS studies, from participants who are not of European descent has increased fivefold, but yet nearly 78% of this growth is due to an increase in the number of samples from East Asia, from South Asia, and Southeast Asia. Okay? So there has been a change. There have been a number of countries in Asia that have incorporated their data into those databases. Together, individuals of African and Latin American ancestry, Hispanic people, Native or Indigenous people represent less than 4% of all the samples analyzed. Collectively, these are the most vulnerable and traditionally underserved populations. So what this says is there has been more ancestral diversity within the Genome-Wide Association database, but from the perspective of underserved populations in the United States, not so much. So why is this important? This is another recent paper that I just want to make reference to. The senior author is Isaac Kohani. And they looked at analysis with regards to misdiagnosis, with regards to gene variants in certain populations. And what they found was because of the lack of certain populations in the database, they weren't able to really ascertain whether certain individuals were actually at risk or not. And because we need more individuals from diverse ancestral populations of the world within the databases to be able to make sense of the information. So it was not able to give the proper information, to give the proper care for the patients that received their genetic test results. So we're dealing with the challenge that we should recognize that we clearly have genomic variation across the world with regards to individuals that has an impact on treatment. And particularly what I would like to focus on is this issue with regards to drug treatment and making decisions with regards to what's the best drug for an individual. Recognizing that each individual is who we should be caring for, but we clearly have population differences with regards to who may have a prevalence of a certain allele or not. And so how do we make sense out of this, and how we make sure that we can use the process of a learning healthcare system and the integration of genomics to help us enabled to provide the best treatment for each individual patient. So I just want to give a context here that, and I'll talk for a minute about the issue of race more broadly. I am not talking about race and ethnicity and racial and ethnic differences in drug treatment. What I am talking about is the difference in the variation based on ancestral population and understanding who are going to have certain side effects or who are going to benefit from certain drugs, and the need to do the studies to understand that. And so this paper identifies a number of studies with regards to drugs that were approved by the FDA, that they have been now requested the companies to go back and do additional studies. And that's where I think a genomic-enabled learning healthcare system can be of great benefit, and the ability to do this research and to do this work on different populations. But we have to have the system set up. I just loved your talk, that if the structure and the system is not set up to do that, we will have the inability to make sure that it benefits everyone. So I'm going to take a minute and give one case study. Some of you I know are familiar with this case study, but I think it illustrates the issue of the potential that a genomic-enabled learning healthcare system can have on our populations, on the health of our country, but also give some context and reality to some of the treatment differences and the challenges that we have. So I'm sure that most of the people in the room are familiar with Plavix, which is a drug that's often used for various related heart diseases and a variety of ways. It's one of the most commonly prescribed drugs in the United States. And a story here is, I think, of importance in thinking about how we can integrate genomic information in learning healthcare systems to actually improve health of populations that may be underserved or left out. So the CYP219 gene, metabolism gene, has differences with regards to the ability to metabolize Plavix. And that becomes extremely important as we think about variation across the globe and individuals who have the G allele and the individuals who have the A allele. So people who have the G allele can metabolize Plavix pretty well, and it's not a problem. But if you have the A allele, it's more difficult to metabolize the drug. So two things here. One is you see that there are places across the world that have both the A and the G allele. So it's not just distinct to one population. However, though, there are some places in the world, because of populations and people mating and just information, where that allele is more prevalent. And so with regards to the A allele, it is much more prevalent in the Hawaiian Islands and in the Pacific Islander communities within the Pacific, okay? So, the state of Hawaii. Over 30% of the population of the state of Hawaii are Native Hawaiian or Pacific Islander, okay? Many of them have the allele that does not metabolize Plavix well, all right? This became an issue because of the challenges within the state with the state Medicaid system and payment of Plavix, that the Attorney General for the state of Hawaii decided to file a lawsuit against the pharmaceutical companies making Plavix, asserting that the companies understood that certain populations did not metabolize this drug as well, and that a significant number of the citizens of the state of Hawaii could not metabolize the drug, and it was being marketed to them. And so this issue, because a certain percentage of the population, over 30% of the individuals could not metabolize this drug well, how can we make sure that they too benefit with regards to treatment with their heart disease? And whether just doing a genetic test and genotyping is the step that really needs to happen, which is not a very expensive genetic test, but a test that's not always done. So if we really had a genomically enabled healthcare systems in the state of Hawaii to help to identify the patients that may be at most risk of not being able to metabolize Plavix, could that provide some benefit and provide more equity with regards to how we use information to provide the best care for all patients and for all populations? So I want to come to the close of my talk and talk a little bit about this question of race and ethnicity and are important for the learning healthcare system. And really kind of following on the first talk this session, this concept of race and its meaning with regards to our health is something that is challenging. And some colleagues of mine and I wrote a piece that was published in the New England Journal of Medicine that argues that actually we think precision medicine will change how we use race in drug treatment, and that the potential of moving beyond race with regards to drug treatment in the future, but that we have three challenges that we have to address. First, we need to increase the inclusion of patients of diverse ancestry and genomics. This is the important message of my talk. Without the ancestral diversity in our research, in our work, and our analysis, we will not be able to do that. Second, control of rising drug costs. This is a huge issue that I think is going to have a significant challenge in precision medicine. And improve the ease and usefulness for implementing a precision medicine approach. I talked to 2 students at lunch, and I know they're going to help to do that as they integrate electronic healthcare records and bioinformatic information into drug and treatment of individuals. But today, it's not the easiest way to get that information and use it at the bedside in providing care. But I do want to say that race and ethnicity are important, as well as other social concepts, in how we integrate that data into electronic healthcare records in a quality way, and then ultimately into decision-making within a genomic-enabled learning healthcare system. So with that, thank you, and I look forward to the panel.
Thank you very much. It's a pleasure to be here. Well, one thing you can tell from the title is that I really, really like acronyms. And I'm sort of the designated acronym maker in our group. I have no disclosures that are relevant for this. Let me just start by saying that the research that I'm going to describe, the first part, I'm going to describe sort of 2 projects, a part of one project and a bit of a part of a second project. And these sort of started in the aftermath of the controversy of the support trial and in my view, as I published this is in a secret, deeply misguided overreach by the Office of Human Research Protection and their criticisms of support. There was a lot of talk at the time that happened about what patients think about this kind of research on medical practices, research involving randomization among usual practices, however, it's comparative effectiveness research, point-of-care randomization, pragmatic trials, learning health system, all these different terms for pointing in some of the same directions. But we really didn't know what people actually thought about it. Nobody really studied that. And so we and some other groups were given some funding to really look at that, to really address the empirical question about what do the public, what do patients think about research, the ethical implications of randomization within usual clinical practices, which we call ROMP, Research on Medical Practices, and how should these attitudes influence policy and about approaches to informed consent. And the results I'm about to present are not just mine, the result of a very large research team of investigators, primarily based at Stanford and Seattle Children's Hospital, as I said, with funding from NCATS and the Greenwall Foundation. And we've already published quite a bit in the last couple of years since we started doing this research. We've published a total of about 10 articles, including all these different empirical pieces that we've published from the data that we've been collecting. Again, we're talking about ROMP, that is research comparing medications or treatments that patients are already already getting, as opposed to rent or research to evaluate new treatments. And again, we know there's lots of different options that people often don't know what's best, and this is research trying to answer those questions about figuring out what those best things are. You'll notice you've seen some of these comic images. As part of our research here, we developed a set of comics and illustrated videos to explain some of the key concepts, and then those videos have in turn been used by some of the other teams that have also been doing similar kinds of research at Penn and Duke and Hopkins. Our overall ROMP study included focus groups and surveys. We partnered with Primer, and we surveyed 1,500 randomly selected Primer members, and we got a 40% response rate of over 500 Primer members we had 600 total respondents, over 500 of them were IRB members or professionals of one sort for IRBs who are included in our data analysis. We also did a nationally represented sample of the public that we did a survey of, as well as patients from specialty clinics in Spokane, Washington. The data I'm about to present is really data that compares this IRB data along with our patient Spokane data. Although, in fact, our findings in the Spokane data was very similar to the findings we found in the nationally represented panel data. And basically we did surveys, two separate surveys of the IRB members, and one of we did the same survey of both the general public and the patients. We used the videos interspersed that we made interspersed to educate people, gave them different scenarios, and it was a mix of sort of scenario-based questions and general questions that we did. And for the IRB group, we had those scenarios without the videos and general questions. And because we weren't sure whether that would make a difference, we randomized, half getting the scenarios first and then the general questions, and half the other way around, and it made no difference in terms of the outcome. We published the results of this comparison in clinical trials recently, and here's some of the differences that we found that are interesting and important. First of all, and just let's see, is there a yeah? So this is a preference for documented written informed consent, verbal consent, broad notification, and no consent at all. And what you can really see very graphically illustrated here is that IRBs see a huge difference, as indeed does the regulatory system, between randomization versus observational medical record review. They see those things as really fundamentally different. And patients don't. Both in our public survey and our patient data, they really did not see a very big difference between those two. And while they want informed consent of one for another, they're a little bit more willing to have verbal discussion. There was just generally, but they were not nearly as, but they saw these things as pretty much the same and not much difference compared to IRBs. In terms of what was the minimally acceptable approach that you had to have in order for the research to be able to go forward, again, IRB professionals see randomization as requiring at least verbal or written permission always, whereas we actually found when we looked at the public, given the trade-off between the value of research and the consent requirements, they were willing to accept broad or no notification as acceptable most of the time. And in fact, this was even more pronounced than in the group of the public. They were willing to lower the consent standards to broad notification as long as the research could go forward. So again, a huge discrepancy between the way IRBs look at things and the way patients look at things. About the question of who can obtain consent, we found also similar differences. These are of the IRB members, and you can see about half thought it was okay to get consent from anybody, either the clinician or a researcher or a study coordinator. But a very significant number of IRB members think that you should never get consent from, or that it would be ethically problematic to get consent from a patient's clinician, and then a small number thought you should only get it from a patient's clinicians. And this led, again, to significant differences between the way IRBs look at this, where in this number you can see 65% thought either a researcher or a study coordinator could give consent, and only 35% would be or should be getting consent from clinicians. In contrast, for patients, it was exactly the other way around. What we saw in our focus groups, what we saw in this data, patients want their doctors to be the ones telling them about it, while IRBs are nervous about having doctors playing that kind of role. There's some limitations to this part of the study since the two surveys were not worded necessarily identically because we weren't necessarily intending to do a comparison, so it was a post hoc analysis. And of course, the Spokane data, unlike our population survey, which was representative, were largely old, white, lower income healthcare users, unlike our general population. But our general population had very similar findings as well. So what are some of the key differences between IRBs and patients? IRBs distinguish between medical record review and randomization, while patients' consent preferences are much more consistent. Patients are willing to accept less elaborate consent approaches, broad notification, or even no consent, even when IRBs identify traditional written consent as the minimal acceptable approach. And patients prefer consent conversations with their doctors, but IRBs are split on whether this is ethically appropriate. Now, and for people who want more information or want to get access, anybody can use these. Our videos, our comics, all of our instruments are all available online, and anybody can get access to them. We've got them all available through YouTube, so anybody can see these 3 videos that we've developed. I want to talk a little bit about ROMP2, which is talking more about electronic health records research, building on that, and also talking about biobanking. And again, most of the same researchers at Stanford and Seattle Children's, though we've added folks from Sutter Health and the Palo Alto Medical Foundation to this project. Again, we engage in a similar kind of activity of creating videos, and so these are not yet publicly available, but soon will be. We've created 6 new, again, short 3-minute videos, illustrated videos to explain these things, and we've got them in English, Spanish, and Mandarin. And we wanted to try and create materials that would be appropriate for cultural context and health literacy of different patients to talk about biobanking and medical record use of medical record research. And we spent a lot of time actually developing the right images, the right metaphors, and the right language for those sorts of things. We don't talk about biobanks because that had different kinds of associations with it. Instead, we call it the Library of Medical Information. So instead of the learning health system, this is the metaphor that we found to be most useful and seem to resonate with most populations. There's lots of others who have studied biobanking. Jeff Bakken, who spoke earlier, has done a lot of empirical work in a lot of populations, but we were including some populations that have not really been very, very well studied so far. And then this is a mixed method study where we've done these video developments with multilingual trigger films. We've already conducted focus groups, which I'll talk about in just a second. And then what we're about to do is an actual pragmatic randomized trial as Sutter is recruiting for their biobank. Coming out of our findings, as well as the work of Jeff and others, we actually think, and Rich had talked about this a little bit, that the oversight and governance approach matters to a lot of these people. So we've come up with an approach to governance that they've adopted and an intervention to explain that governance. And so and they're doing the recruiting, they're being randomized to getting in the recruitment information about the governance structure. And we're going to see whether it actually has an impact on recruitment, and especially recruitment for underrepresented groups. And we're also going to be doing follow-up surveys of those people to see whether or not it impacts their trust in the system. So we've done focus groups and analyses, 20 focus groups of their patients, including 4 groups of African-American patients, 4 groups of Chinese patients, 2 of which had people who spoke English, 2 that were conducted in Mandarin, 2 in English and 2 in Spanish for the Hispanic population, 4 non-Hispanic white groups, and 4 groups representing South Asian populations conducted in English, a total of 122 participants. Codes were developed. We had a good inter-rater reliability in our analysis, and then we did a team-based thematic analysis. There are 4 themes that came out of this that were, I think, really interesting that came out of our data, and that resonate with a lot of what's already been talked about today. First of all, the framework, in a way, it's very different. Our regulatory system is really framed on issues about autonomy and risk. And that's really one thing we heard in all of the ROMP 1, ROMP 2, everything we've heard is that's just not how patients look at things. They don't look at things primarily in terms of either risk or in terms of autonomy. They tend to think of it in terms of issues of trust and trustworthiness. And so that became a really major overarching theme, is that their support of the Library of Medical Information is conditional on institutional trust. Yeah, they're concerned about appropriate access and use of the library and resigned to worries about data breaches. They do view consent as important for demonstrating demonstrating respect, but like our studies in ROMP1, they recognize its trade-offs and limitations, and most people were willing to say if the consent requirements got too burdensome and made it too hard to do the research, they mostly wanted the research to go forward, as long as it was done in the right way, in a way that was trustworthy, and their trust in the library depended on the existence of oversight and governance mechanisms that met their expectations. I'm only going to focus on that first set of theme about institutional trust. All groups expressed general willingness to participate in the library and said they believed research would benefit future patients or individuals like themselves, and recognized limited applicability of current research findings because of the historic enrollment of white males in clinical studies, and expressed the view that different racial and ethnic groups have different health problems, and use of racial and ethnic identifiers in research could help address those problems. But their willingness to participate was conditional on trust in physicians, researchers, healthcare systems, government, and corporate institutions. And while lack of trust was expressed in all groups, historical discrimination and abuse was especially brought up in the African American groups, while other groups, especially the Hispanic, Chinese, and South Asian groups, suggested there's a general lack of engagement by recent immigrants because they are unfamiliar with the healthcare system and research, and that this is an underappreciated problem that they think needs to be addressed as well. And patients were more willing to participate if there were assurances of transparency and that patient concerns would be addressed. So where do we go from here in all of this? One of the primary roles of informed consent is to demonstrate respect for persons. Our findings reveal discrepancies between the way that our regulatory system and our regulators view these issues and the way in which the public and the different publics view these issues. Policy deliberation among IRBs, research, and the public can help develop an approach that both respects participants and achieves research goals to improve healthcare. And I want to end with a wonderful quote from John Lantos in an editorial he wrote that accompanied our first empirical piece that we published in Annals of Internal Medicine. It is time to ask whether a system in which the fundamental principle is respect for persons can continue to ignore the preferences of many of the persons it claims to respect. Thank you very much.
Thank you to all of our speakers for those wonderful presentations, and hopefully that will stimulate a lot of questions from our audience. If you have questions, please start to line up behind either of the microphones, and while you do that, I'll get us started with one question that I'm going to pose first to Scott and then to the rest of our panelists. And that is, if you were to have to name one area of future research that we would undertake as a top priority to ensure that a learning health system is equitable, what would that top priority for research be?
Well, I guess, I don't know if I have a very specific recommendation here, but I think this idea in research of kind of thinking about social justice issues at the onset, even before the research project, even within the funders in terms of how they construct the RFA, I think is an important element to consider. And I guess I can use as our example, I'm involved with a precision oncology project here at the U of M. And the first round that we've engaged in, we've kind of had some of the same challenges that I think a lot of the other sites around the nation have had, and that because we're kind of working with our existing system in terms of the kinds of patients we're bringing into our trials, we don't have the kind of racial and socioeconomic diversity that I think we should have. But interestingly, in the kind of renewal, I think to their credit, National Institutes of Health have thought about these issues, and so part of the second round of funding is requiring that all populations have to be at least 25% underrepresented minorities. So I think that has forced a lot of the leaders in the field to move outside of their comfort zone, not just accepting who's walking in, but thinking about these kinds of partnerships with community-based hospitals and different stakeholders who maybe aren't usually part of the NIH research process. And I think that's important because that's going to help translate these findings more readily. But I think we're still dealing with the challenge, even if those trials are successful. I think Dr. King-Ori's comments really resonated with me because we're still dealing with a lot of these technologies that, at least for the short term, are really going to require costly technologies. They're going to require proximity to locations that can deliver these technologies, and they're going to require highly specialized professionals that aren't in much great numbers. So I think even with some of those incentives in building the research, we're still going to be faced with the challenges once we ultimately move to translation of some of those structural deficits and really being able to realize the promise, whether it's of precision medicine or learning health systems.
So in a way, my answer has two parts to it. I think one of the things that we need to recognize is that right now, the way we think about informed consent and to some extent even recruitment is still very much print culture oriented and not a recognition of the fact that we live in increasingly in a screen culture world. And so, I mean, folks at Sage BioNetworks have been really at the forefront of changing that and doing sort of more cutting edge. So but that links with what I really think is really important, which is we need to do a lot more empirical work to earlier on, and this reflects some of what you were just saying. We need very early on to do research to find out what different approaches to recruitment, consent, and participation have what results on different populations. Because if we wait until later and say, gosh, how come we don't have any of these different groups that we wanted to have recruited and they're underrepresented, that doesn't just happen. It's because of the function of the way things are structured, and we can figure some of that out in advance by doing trials and by building different methods and mechanisms of recruitment and finding out what differentially results in different recruitment rates so that we can right from the very beginning take advantage of new technologies and new approaches to recruitment to get a broader range of representation. It's a hard problem, especially illiterate populations, where if you're thinking about the advantages of the learning healthcare systems and precision medicine for the people who are really poor, illiterate populations who may not be technically very savvy, where it's very, very hard to reach them, and recruitment for them we know is already going to be very, very hard. Trying to find innovative ways to reach those populations is especially important. But we have to figure out what works right from the beginning and do that research to answer those questions.
So I have two comments with regards to that. I think the most important is how we integrate more social data into electronic healthcare records in a way that we can use it in analysis to look at both the individual and at the community level with regards to the social context. So coming from the Genome Institute, I think that is the important thing. I think there's a challenge right now in how to use the social data we have in electronic healthcare records and how better to be able to integrate it with other data. But I also, as I articulated, think from a genomics perspective that we must have much more diverse populations in our studies. If we're really going to be able to get to a point of precision medicine for all populations, we have to have the diversity of individuals and backgrounds to be able to help to make sure that be realized.
I suppose my comment, if I only have one comment really, which is to produce equitable research and equitable health systems doesn't happen by accident. Actually requires concerted effort and requires a lot of thought in the construction of those health systems and the data. And I think that's really important from the offsets to look at the building blocks of everything. So I don't think, in thinking about trying to produce something that's equitable, I don't think that we can often operate thinking that everybody assumes and thinks the same way as we do. I've just come in from the UK with Brexit, and the Donald Trump election has shown us that actually we spend a lot of our times with people who often think very much the same as we do. We need to try and find ways to expose how we think to a broader audience to try and get as many views on as possible if you want to be representative of lots of people.
Yes.
Hello. Just as a disclosure, again, I am from the U of M IRB here. I guess I had two different comments or questions. In looking at the results from the ROMP study where IRB, for consent for randomized trials was so much higher, where thinking consent is important there versus patients' view, how much did it, or can you talk about what we think about is what patients, they don't know what they don't know about a trial. Do you have any questions about this? And it's like, yeah, no, I don't. I don't even know what to ask as a patient. And how much did that play into there? And then also this concept of patients really wanting institutional trust. They trust the institution. But behind the scenes there's a lot of institutional culture that goes on that is implicit in how an IRB works, depending on what IRB you're looking at and what institution you're looking at. And so to, you know, I feel like there's this push to, like, you know, recognizing that, you know, the current system needs to evolve. It's so obvious. You know, I think we all feel that tension there. But how does, you know, looking at the institutional trust there, I just feel like they're always in the interest of the institution. Where's the separate perspective of the patient advocate there?
Well, thank you for well representing the IRB perspective. I'm an IRB member as well at Stanford, and I'm on the Precision Medicine Initiative centralized IRB. So I appreciate that. But I think it highlights, though, a fundamental challenge, which is it may be that there's no question that part of it, anytime you're doing something where you're talking to patients or the public, you have the problem of how much do they really understand. Although there are other areas we were very worried about a lack of understanding, and we've called it the Emily Latella problem, which you have to be a certain age to remember Emily Latella from Saturday Night Live, where she would go, well, you know, what's all this talk about the death penalty? Don't deaf people have enough trouble without the Supreme Court saying in on a death penalty? And then she'd be so you do worry about the Emily Latella problem if there's a lack of fundamental understanding of what the issue is. We put a lot of effort into trying to address that through our illustrated videos, through a lot of detailed in the scenarios. We also did follow-up interviews with people. And although there might have been some areas of misunderstanding, I don't think that, like, not understanding the risks were part of it. But I think what you're saying reflects a more fundamental distinction, which is what John was talking about earlier, which is, and I've seen this when we've talked about our results with different IRB groups who object to the idea that, you know, well, doctors shouldn't be the ones doing the consent. They're conflicted if they're researchers too, and it's really problematic. And it reflects two things. One, which is it's very hard to go from data to policy in a straightforward way, right? So this is how patients look at it. Here's how IRB looks at it. That doesn't mean the patients are right and the IRBs are wrong, but it means that there should be more of a dialogue. But I'd also say that I worry, as John does, that it reflects a certain perspective that I thought you illustrated well, and I don't mean this to be a criticism, because as I said, when I put on my IRB pad, I put on that perspective, which is research is this scary, dangerous, bad thing. We're looking after institutional interests, not the patients. There's a sort of very negative view about what research is about, which I think is an appropriate attitude to have towards rent, but I don't think is an appropriate attitude to have towards ROMP. And so I think that's part of the problem is we're so used to thinking that everything is like gene transfer research. We've got to protect people from the therapeutic misconception and all these other problems. The bigger misconception we've seen in our research is not therapeutic misconception. It's what we're calling the investigational misconception, and people assuming that research has to have something new and something different being done and something risky, which is just not true for this kind of research. And so I think that sort of very negative perspective really just doesn't work for ROMP in the same way, which is I think why in a way we're here and why there's this big debate is figuring out what to do about this stuff, where those lines between research and clinical care and QI are all being blurred. But I think that sort of skeptical attitude, the institution's looking after itself. No, if you're trying to improve quality and make sure you really are looking out for the patients, and that really is what you're doing, and it's not the same thing. And I think that skeptical attitude is not warranted.
Next question then.
It's really hard to come up here with a question and then get such great feedback from the prior question that you start thinking about.
You can change your question.
Well,
we won't know.
One of the things that I've been thinking about, you know, from a disparities perspective, race and ethnicity is really easy for us to observe in a way compared to some of the other disparities that might exist. I was at the Interagency Autism Coordinating Committee. We got some presentations from our friends at the UK. They were looking at epilepsy. And one of the exclusion criteria for epilepsy to be included in any of the trials that are part of standard of care has always been that you're not on the autism spectrum. Yet 30% of the population of autistic people have epilepsy and they're being treated by that standard of care. So I think anytime a particular population that we can put an attribute to is excluded by design, we have something to look at that will more, maybe getting to that, it's not about our race or our ethnicity, but who we really are and what our biologies are different, and looking at it from that perspective versus some of the obvious things that we can see when we look at one another.
Comments?
So I would just say as we think about big data and bringing data together to understand diseases better, putting the context of an individual both around their clinical phenotype and diseases, but also the social context and where they are, and you know, a number of things about them socially is so important. And so, you know, when I use race and ethnicity as an example, that's a social context, but there are so many other social contexts. So I agree with you. And I think the challenge is how are we able to do that in a precise way and use that information and analysis? And I think that's where we all kind of together have to grapple with to really to make sure that everyone benefits.
I thought that was a really interesting example, actually. Thank you very much for that. I thought the other thing, based on what you said, was that if I'm using that data, I mightn't necessarily be aware of this exclusion criteria. I'm just looking at it on the basis of people who have autism, not knowing that a whole selection of the population who have autism have been removed from that data. And so this is one of the things I find really interesting about integrating and pulling data from lots of different sources, is all of the assumptions that are embedded in the data that you inherit, and how all those things feed into much more a larger data set, which have been compiled from all these metadata with all of these assumptions in it. It's producing something else. And so it's a really interesting challenge, I think, looking at how do you capture all of these assumptions and exclusions and inclusions when you're thinking about making big generalized statements on aggregate about a population.
Yeah, your comments make me think about the challenge that we saw, for example, in generalizing clinical trials data from psychiatric medications to child and youth populations, where the trials weren't necessarily done. We don't know the risks, but yet commercial pressures are leading towards kind of expansion of the category of patients who get those medications.
Jeff, go ahead.
Yeah, I think my question is probably consistent with the last one, and statistical question, so maybe relaying my ignorance. But we have a tremendous problem now with reproducibility of studies. I think everybody's recognized the magnitude of that problem. And a component of that is a lot of underpowered studies. So if we work hard and try to get minority group inclusion to 15 or 20% of a bunch of underpowered studies, have we really learned anything about those individuals who come from those minority communities? So that seems to me shouldn't be the short-term goal, is just to get representation up to the population levels, but rather to get representation up to the levels where you can draw valid conclusions about those subgroups in ways that are robust.
Yeah, I think that's an excellent point. I think one of the things we've seen a move towards is recognizing that sufficient power is only likely to be reached if you have these kind of large consortia and data sharing across groups. So I think we've seen a lot of move towards these multi-site, multi-institution projects to try to get beyond this issue of underpowered studies. But those then bring in new challenges in terms of coordination, harmonization of approaches across sites. But I think that's where we're, at least, like I mentioned, the precision oncology space, where we're seeing the field move.
I think I think your point is really important and well taken. That's really why it's important for at least some of the studies that are being done, for there to be oversampling of some of those populations. I know for the biobank, we're partnering with, they're oversampling some of those different groups as they're building the biobank, and I know that's certainly something PMI is intending to do. It's always disheartening, though, when you're looking at the data coming in from a group that plans to do this oversampling, and then the data comes in, and it's like the traditionally well-represented groups, recruitment's fine, and then these other buckets that they plan to oversample are just not coming in as well. So that's why, again, we need to figure out better ways of figuring out what works well for the recruitment efforts to be able to make up for that problem. But I think it's important to not just, I think your point is well taken about combining data sets, but I think it's also really important that we do a lot of systematic oversampling of underrepresented groups.
Just want to make one comment that the National Human Genome Research Institute is clearly recognizing this problem, and some of our new initiatives, we are taking a very different approach. So the CSER2, or the Centers for Exploratory Genome Sequencing Integration into Clinical Care, we now have a component that requires individuals who apply for one component of that initiative to have at least 60% from the population, an underserved population that they are have identified for their study. So that's really taken it to another level. And I think this then gets back to the conversation about engagement and back to your comment, is this then having an honest engagement and involvement of the communities that you're seeking to have in these studies. And that's where the hard work is going to have to be done from the perspective of how do you really build the trust and the relationship and the long-term relationship so that when you're here in Ann Arbor that you actually do have people outside of your healthcare system that you engage around your research.
Go ahead, Sharon.
So I wanted to sort of build on the last piece that, Vince, you just talked about, because one of the things which sort of, I'll conceptualizing from a more public health point of view, is that sort of healthcare systems and hospital systems within a county, a state, serving the people of that region have kind of one set of ideas about how to sort of improve medical practice. And in many ways, we're building these large systems, the learning health system being an example, in order to do that. But then often there's not this kind of anchoring of those institutions within those communities. They're not using the locally sourced sort of, I'll call it companies and businesses. They're not actually building what would be those pipelines that would actually, I'll call it, pour the benefit back in to the communities themselves. And that in some ways, Patricia, the sort of structural pieces of we're generating new knowledge, but how would the people ever really know whether or not it's benefited them? In some of the work Jody and I have done surveying people, it's true their sense of benefit is directly related to how well they feel connected to the institution. I mean, we could easily ask people, how do you feel about donating your electronic medical records to research? Or we said researchers, and the number was not nearly as high as if you say researchers in your state, right? Huge significant difference if it's somebody I can relate with. My doctor being another one. But in many ways, when we did that same kind of work, what we saw was also a whole set of people that do not feel good about their institution, don't really feel like they're getting a lot of benefit, not having a great medical experience. And in our current setup, Ray and I were talking about this, we have consent forms that hardly anybody can read, that have, 10 or 12 pages of dense type. And in the example of putting it within a video, Ray was talking about some of the preliminary work shows that people are not giving as much consent in that more easily to understand format. And that non-consented group are the ones that probably do not feel all that close to the institution. And so now we've got a noticeable gap that creates, I'll call it another disparity of whose data gets in and who will be used for. And then I'll end with my concern that then as researchers, as an institutional, I'll call it society holders, we then turn to manufacture trust. And that some of what I fear is that we are in the business of manufacturing the trust that we want people to actually participate, and in the end may not actually benefit them because we're taking correlation as causation, and because we don't have the reproducibility. And where are some of those bigger equity issues in the structural way in which we've set things up?
Who wants to respond to Sharon's question?
I'll just say right on, Sharon.
I think I agree with just about everything you said. I think ultimately the best way to be, though, is to be a trustworthy entity is the best way to engender trust. That's the way we think it should be done. And if it's too late, if you're sort of late in the game and you're getting a disparity because people aren't coming to you. This goes back to what Rich talked about earlier. That's the wrong place to do it. You don't do it at the end. You do that earlier on at the beginning by being the kind of institution that's trustworthy. But it's a different framework. It's not the way our regulatory system works. We don't focus on being trustworthy. We have a very thin, we don't even focus, as Jeff said earlier, we don't focus on the responsibility of investigators. We don't focus on any of the sorts of things that we really need to. as a system in order to be able to build those relationships, and we don't hold people's feet to the fire in the way we should. So I think you're right, but I think it pushes it back. It's upstream is when we got to fix it.
Go ahead, please.
Thanks. I don't know if I have the courage to follow Sharon, but thank you. Thank you to all of you for wonderful presentations and wonderful discussion. My question is to ask you to comment more generally on the double bind, and you've talked a little bit about oversampling, but the double bind that many of the groups who we want to see more heavily represented in genomic health learning systems are the same groups that are, for very good reasons, defined as especially vulnerable in the IRB system: prisoners, pregnant women, children in research where they have otherwise been excluded. So that seems to me to create something of a double bind in terms of equity issues, and I wondered if you could just comment on addressing that double bind systematically.
So I agree. It creates the challenge because of that. I guess my reaction to your comment would be this, is that one is there are some populations that I would not consider in that protected vulnerable group that we are missing, that we can do a better job, okay? And so I think that's extremely important. But then thinking about those vulnerable populations that we also want to participate in is how do we set up the design and the systems with the researchers, the IRB working to help them to engage in an appropriate way to protect the interests of those communities, let's say incarcerated individuals, but also not to leave them out. And so it creates more time, it's more work, it's more resources, there's a lot more to it, but I think we have an obligation to it. But my comment would be is there are significant populations that are left out that don't fit those categories, and I think that we must do a better job with those populations at this point.
Thank you so much for answering all the questions, and round of applause.